All right, we're going to get started. Welcome, everyone. It's evening. I'm in a different place. We want to welcome you this evening to the Choroideremia Research Foundation webinar number 2 for 2025. And it's a really great topic to launch our webinars. So welcome. I'm at home and it's snowing in southern Lancaster County. So we're going to hope that the internet holds out well, and I'm sure it will. But tonight, we're excited to have one of our very own here with us tonight, one of the family. Mira Furgoch is here, and she is a genetic counselor and also a carrier woman of choroideremia. So tonight, we're going to talk about a topic that has really been one that has been discussed a lot at our conferences, one that comes up often in discussion groups, and it certainly isn't with choroideremia only. It's about family planning and what topics to think about, what questions to ask. And as Mira said in the description, and that you guys read in the invitation to attend tonight, there isn't one way is the right way. So we're really looking forward to, we're recording it, as I said, but we're looking forward to any questions that you might have. There's really nothing out of turn. We'll be taking questions a couple times during our sessions tonight. It's a small group, which is really intimate and nice. But Mira, thank you so much for joining us. You're coming out of Canada, right?
I am. It's snowing here too, so but I'm not worried about the power.
I think your temperatures are probably cold, and as in the United States, if anybody else is weather nudgy, you'll see that this big Canadian polar vortex is making its way into the US just this weekend, and everybody's batting down the hatches.
Mhm. Yeah, I have a lot of coworkers that are in the US, and they have all been, sharing their weather stories as well
Oh
this
my
last week,
goodness.
so everybody's getting a taste of winter this January.
It's true. Well, I'm going to go ahead and turn off my volume and certainly my camera. You can share your PowerPoint. And folks, just as a reminder, please use the chat feature or the Q&A. I'll keep tabs on all the questions and I'll give them to Mira as she um, presents tonight. Thanks so much.
All right, perfect. So I'm gonna share my screen. There we go. And if you catch me looking in different directions, it's because I've got multiple screens going here. But thank you for the introduction. Today, we're going to talk a little bit about family planning options with choroideremia. And disclosure that I have to start off with is that I am a full-time employee of Cooper Surgical. So this is a lab that provides genetic testing, but the views that are expressed in the following presentation are my own and not necessarily those shared by Cooper Surgical. To preface our discussion, this webinar will be reviewing all of the options that are available, but as we already heard, there's no one right or wrong option for any one person. The way that you grow your family will be unique and will take into consideration your own experiences, values, and so much more. Additionally, it's possible that not all of the options that are discussed today will be available to everyone depending on where you're located, for example. So, this presentation is for the purpose of education. So, it's not intended as specific medical advice for any one individual. Choroideremia Research Foundation, Choroideremia Research Foundation Canada are not specifically advocating for, recommending, or advising any one of these particular options. And you're going to want to speak with your own medical provider or a clinical genetic counselor to further discuss what options are going to be best for you. So I was already introduced a little bit, but I am a genetic counselor. I have worked in a prenatal setting, a pediatric, and adult setting in both the US and Canada. And I currently work for a lab that specializes in preimplantation genetic testing. And I am a CHM carrier. I'm a daughter of someone with choroideremia. And if you have been around the CRFC, you'll probably recognize my last name. Today, I like to start by going over a background of choroideremia and the inheritance. We'll discuss the family building options for carriers and also briefly discuss the family building options for affected individuals. I also have some resources that I'd be happy to share. And then again, we're going to have lots of time for questions. I'm going to take some breaks in between, but certainly if you've got questions about anything that we're talking about, put them in the chat and we can sort of answer them as we go as well. To start at the very beginning, people will typically have two copies of their genetic information. So we're going back to biology class. One of these copies we inherit from either of our parents. And then when we go to reproduce ourselves, we'll pass on half of that genetic information into our eggs or into our sperm, depending what we've got. Our genetic information is packaged into what we call chromosomes, and these are numbered in their pairs from chromosome number 1 all the way up to chromosome number 22. And then the last pair are the sex chromosomes. So people will usually have two number 1 chromosomes, two number 2 chromosomes, all the way up to two number 22 chromosomes, and then typically have two sex chromosomes. So generally, women are going to have two of the X chromosomes, and men usually will have one X and one Y chromosome. Choroideremia is caused by a genetic variant, sometimes called a mutation, in the CHM gene, which is located on the X chromosome. So this would be considered what we call an X-linked condition. Therefore, females who have two X chromosomes are typically expected to have two copies of the CHM gene, and males are expected to have one X chromosome, one Y chromosome, and would therefore have one copy of the CHM gene located on their single X chromosome, and then that Y chromosome does not have a copy of the CHM gene on it. So, for an X-linked condition like this, if a male is affected with choroideremia, what this means is that his one and only copy of the CHM gene on his one and only X chromosome has a genetic variant or mutation on it, which causes it not to function in the usual way. So, when he goes to pass on his genetic information to his children through the sperm, there's going to be a 50-50 chance whether that child would inherit the X chromosome or inherit the Y chromosome. If they inherit the X chromosome, they also inherit that mutation. These children are also all going to inherit an X chromosome from their mother, who we're going to assume in this case is not affected or a carrier with choroideremia. So, what this means is that all the daughters of an affected man are going to be carriers of choroideremia. Sometimes they call that being an obligate carrier. And they're going to have one normally functioning copy of that CHM gene and then one copy with a genetic variant, so not typically functioning. All the sons of an affected man would be unaffected, having inherited that Y chromosome with no copy of that CHM gene. Now, I do want to mention, for the purpose of today's discussion, anybody that has two X chromosomes, one of which has a CHM mutation on it, is going to be referred to as a carrier. But I do want to acknowledge that even those individuals who are carriers may experience symptoms related to choroideremia. But this is not really the primary focus of today's discussion, and it doesn't really affect the reproductive options that somebody has available to them. So, while we can certainly touch on it if people have questions, I'm not going to go into a whole lot of detail about that right now. For someone who is a choroideremia carrier, they're going to have two X chromosomes. One of those will have a normally functioning copy of the CHM gene, and then one will have that non working or not typically functioning copy of the gene with that genetic variant or mutation. When they pass their genetic information on into their children, we'd expect for there to be a 25% chance that that child would inherit the X chromosome with the mutation from their mom and a Y chromosome from their father. This would result in a child who's an affected male. There would be a 25% chance that a child would inherit the X chromosome with the mutation and an X chromosome from their father. This would be a carrier female. And then there would be a 50% chance that a child would inherit the X chromosome with the normal copy of the CHM gene from their carrier mother, and then either an X or Y chromosome from their father. This would result in an unaffected daughter or son. When it comes to family planning and considering genetic testing or diagnosis of the next generation, knowing your specific CHM genetic variant or mutation does matter. And there are several different ways somebody could go about getting this kind of genetic testing done. In the US, the Foundation Fighting Blindness does offer free genetic testing through the My Retina Tracker program. And there's a link for this on the CRF website, and I have the link in my resources at the end as well. Testing may also be available through your own medical providers, maybe a primary care provider, maybe ophthalmologist, or maybe somebody else. And for someone who is a known or suspected or obligate carrier who hasn't had genetic testing for themselves, the CHM gene is often included on what we call expanded carrier screening panels. These are genetic testing panels available more broadly to anybody of reproductive age, and a genetic counselor, possibly another medical provider, may be able to order these tests. These expanded carrier screenings would look not just for CHM, but would look to see if somebody's a carrier for other kinds of X-linked conditions or recessive conditions that someone's children could potentially be at risk for. So something else people can explore. Don't know if there's any questions so far about that sort of background information. If there are, I can take them now before we dive into some of the family planning options, or else we can keep going and
You can keep going. There's not any questions
okay.
yet.
All right. So this is the more exciting part. Um, so in reviewing the family building options for carriers, I'm going to go into some of these in more detail than others. But if you have questions about anything that I don't go into a lot of detail about, again, I'm happy to dive in. And the amount of detail that I'm going into in these slides doesn't mean that any of these options are better than others, but they're the options that people often have the most questions about and that I'm the most qualified to discuss. I do also want to note that these options are the ones that are most often available in places in the US and Canada, but some may not be available in all locations. And so, again, this is why it's important to speak to a local provider, a genetic counselor about what options are going to be available for you specifically. So, we'll review the options that are available with a natural conception, with or without genetic testing. We'll discuss the option of in vitro fertilization with preimplantation genetic testing. A mouthful there. There's also other options that I'll touch on, including things like using donor eggs or embryos, adoption, and in some cases, medically indicated sex selection. And although not listed here, of course, everyone always will have the option to choose not to have children, not to reproduce at all. So, first option we'll go into will be the option of a natural conception. So this is the least involved and invasive option that people have available to them, and it's kind of the default to conceive naturally with no genetic testing. In this scenario, the chance to have a pregnancy or a child that's affected or a carrier is expected to be in line with that inheritance pattern that we were discussing earlier. And I've got repeated again here on this slide in the picture. So for a carrier, this would mean a 25% chance to have an affected male pregnancy, 25% chance to have a carrier female pregnancy, and a 50% chance to have an unaffected pregnancy, either male or female. In any conception, there's also the option for prenatal testing. So, this is genetic testing during a pregnancy. And the earliest kind of genetic screening that's available goes by several different names, such as NIPT or cell free DNA testing. And this test is done as early as about 9 to 10 weeks along in a pregnancy. And it works by looking at the free floating DNA in the maternal bloodstream, some of which originates from the placenta of the pregnancy. So it can actually get some information about the genetics of that ongoing pregnancy. This test can screen for the chromosomal sex of the pregnancy. So whether that pregnancy has two X chromosomes or if it has one X and one Y. Additionally, this test can also screen for a few other non-inherited genetic conditions, such as Down syndrome, for example. Now, this is a screening test, so it does not have a 100% accuracy, But it may be helpful if someone just wanted a little bit of information or they wanted some guidance, maybe before pursuing other genetic testing. We'll talk some more about some of those other options in a moment. Often, this is a test that would be covered by insurance or by provincial health care, but if not, self pay costs are typically less than maybe $500 or so. But again, this does vary. And this is a kind of screening test that can be ordered by your prenatal care provider typically, or possibly by a genetic counselor. Again, varies a little bit depending where you're located. Other prenatal options include what we call prenatal diagnosis. So these would be tests that are available during a pregnancy if someone wants to find out for sure if an ongoing pregnancy is affected with choroideremia, or if they're carrier of choroideremia, or that genetic variant. And there's two different kinds of diagnostic tests that are available. So a CVS, or chorionic villus sampling, can be performed at around 11 to 14 weeks along in a pregnancy. And it's a procedure where a biopsy of the placenta is taken. It's done in one of two ways, either transcervically, so with a catheter through the cervix, or transabdominally with a needle through the belly. The other option is an amniocentesis, which is performed after around 16 weeks, and it uses a needle to obtain a sample of the amniotic fluids, the fluid that the baby is floating around in. Doesn't poke the baby or anything, but that fluid actually has cells that come from the baby's digestive system. So you can do genetic testing on that, and it's representing the baby. Now, today, both of these procedures are done using ultrasound guidance, and they are considered quite safe. But as they are both procedures, there does remain a small chance of complication. Typically, that's quoted as less than 1%. And the samples from these procedures can be used to directly test for the choroideremia genetic variant that's known in the family. Again, known in the family. So you would have had to have genetic testing yourself and know that genetic change. Um, but in addition to looking for a known genetic change that's being inherited in the family, they can also screen for or test for other genetic conditions as well. This includes, again, chromosome conditions that are typically non-inherited, like Down syndrome, for example, or if there was something else that was, inherited in the family, they may also be able to test for that. While it's, of course, important to consider how you would feel or proceed dependent on the different outcomes from this kind of genetic testing in pregnancy, I do want to make it clear that having one of these procedures doesn't mean that if it was to come back positive or showing that a pregnancy was affected, that the individual would be expected to end a pregnancy. The decision of what someone does with the information from prenatal testing is always going to be up to them in discussion with their prenatal care providers. Any questions about those options at this point?
You're doing such a fabulous job. There's no questions yet. You're doing
All
great.
right.
Thank you so much. Keep
All
going.
right. Well, of course, if things come up at the end, we can always go back. The other option I wanted to go through was in vitro fertilization, or IVF, with pre-implantation genetic testing, so PGTM for choroideremia specifically in this case. In vitro fertilization, or IVF, this is a form of assisted reproductive technology. So it's a process where the eggs are fertilized outside of the body to form an embryo, which is later transferred back into someone's uterus. So IVF is often used if somebody's experiencing infertility, but it can also be done in other cases. And one of those reasons might be if someone wants to pursue IVF in combination with this pre-implantation genetic testing for monogenic disease, another big name here. Short form for that is PGTM, and that's genetic testing on an embryo for a specific inherited condition. And so if a CHM carrier and their partner were interested in IVF with PGTM, they would work with a fertility clinic who would run some standard tests to make sure that they're candidates for IVF. They would use medications to stimulate her ovaries to mature many, many eggs. And the eggs that would be collected from the ovaries would then be fertilized by her partner's sperm to produce embryos, which would then contain the genetic information from both that egg and sperm, still all outside of their bodies. The fertility clinic would let those embryos grow until they're about 5 or so days old, at which point they would look at them under a microscope and they could see that the ones that have matured have divided into two distinct groups of cells. There's an inner cell mass, which is kind of like the yolk of the embryo. That's what would potentially be developing into a baby. And then there's an outer layer called the trophectoderm, which is what would be developing into the placenta. And the fertility clinic would take a biopsy of about 5 or so cells from that outer layer that would be sent to a specialized lab for the PGTM, the specialized genetic testing. The embryos that have been biopsied, these would always stay at the fertility clinic and they'd be frozen there until the couple is ready to make a plan for what to do with them. When a couple gets the results back from the PGTM testing, they would work with their fertility clinic to hopefully select an embryo for transfer back into the uterus. So, really, the goal, if someone was looking to pursue IVF with PGTM, would be to reduce the chance of having a pregnancy with choroideremia. Now, this is a time consuming and complex process that I've oversimplified first a little bit in that last slide. Um, and the testing of these embryos, it's quite different than genetic testing that's done on a blood sample or a saliva sample or even the amniotic fluid sample from a pregnancy. And this is really because with this kind of testing, the DNA sample you get from an embryo is so, so tiny. Because of this, PGT labs have to develop a custom genetic test for each couple that comes through for this kind of testing. Linkage analysis is the name of this kind of testing method that's used for PGTM. And if a couple was pursuing this testing, they would again need to have their own custom tests developed. And developing this test can take anywhere from approximately 1 to 3 months or so, depending on your specific situation and the testing lab. Involvement of family members, such as your parents or children, in the development of this test is always also recommended. And in some cases, it may even be required. I'm going to give a little example of how this whole linkage analysis things work because it is kind of complex, but I think it's important in understanding how people may be helpful. In this example here, Mary is a CHM carrier. So she has one normal copy of the CHM gene, one genetic variant copy. Partner John will be providing the sperm. He is unaffected. He has one normal X with the CHM gene and then one Y chromosome. To develop this PGTM test, a DNA sample is collected from Mary and John. And these samples are used to look for the linkage markers used for the analysis. So these markers, these linkage markers, they're kind of like unique barcodes that Mary and John have around each copy of their gene or each of these chromosomes. Now, looking at John and Mary, we see 4 unique marker sets. So 3 for the X chromosomes, and then there's 1, of course, for the Y. However, we don't know which of Mary's marker sets is associated with her normal copy, which is associated with her mutation or genetic variant copy. To determine this, we're going to use a second generation in Mary's family. In this case, Mary's parents will be utilized. Her father is affected with choroideremia, and her mother is not. So DNA samples are going to be collected from Mary's parents, and they're going to be used to look for the markers surrounding their CHM genes. Again, think of these like unique barcodes. Now, when Mary's markers are compared to her parents, we can see that she inherited this purple marker set or barcode from her mother. And since her mother's unaffected with the disorder, we know that that purple barcode must be Mary's normal copy. We can also see that Mary inherited the orange barcode from her father. So that's the one that must be associated with the mutation because we know that she inherited that genetic change from her father. So that's the one that's kind of got that red flag associated with it. Because of that work that's done comparing Mary to her parents, when it comes time to actually look at embryos, we now know that any embryo that inherits Mary's orange barcode is going to be the one that's inherited the CHM genetic variant, and anyone that's inherited the purple barcode will be one that's unaffected. And so the couple could then choose to select an embryo that tests as unaffected and transfer that one into Mary's uterus to avoid passing on the CHM genetic variant to the next generation. This kind of testing would differentiate as well between an embryo that's affected or an embryo that's a carrier. Now, some special considerations with this approach are that not everybody is a good candidate for IVF, and this does require a workup with a fertility clinic. The development of PGTM tests, as I mentioned, can take a long time and it can be pretty involved. And it may take multiple cycles to get embryos that people are looking for, depending on exactly what their criteria are for embryos they consider acceptable for themselves. Not all IVF embryos transferred will result in ongoing pregnancies, and there's possibilities that they can fail to implant into the uterus or can miscarry. So it's not a guarantee of success. And additional screening is also available on these embryo samples, including something called PGTA, which screens for chromosome conditions, which are those same things we've been mentioning a couple of times. These are typically non-inherited conditions. Common questions about this option is the cost. And here I provided some estimates, but please note that these can certainly vary greatly depending where you're located. And IVF, it often costs between about $10,000 to $20,000 per cycle. And while there are some states and provinces that have IVF coverage, most do not. Some insurance companies also offer IVF coverage, but again, many don't. So often these costs are out of pocket. PGTM costs range from about $3,000 to $8,000, but this depends on the fertility clinic, the lab that's being used, and the number of embryos being tested. And again, while sometimes these are covered by insurance, a lot of the time they're also out of pocket. Now, these costs and coverages are ever evolving, and I feel like we're seeing more and more coverage, but there's still a long way to go. Any questions so far about this option?
The only question that came in earlier,
Mhm.
Mira, was the IVF success rate.
Mhm.
Are you going to be talking about that later on, or someone just asked, what is the success rate of IVF because they've experienced or heard that it's less than 50%?
Mhm. So there's a lot of factors that go into an IVF success rate because there's so many kind of stopping points along that process. So sometimes people may get a workup with a fertility clinic and find out that they have very, very few eggs, and that they can do an IVF cycle and retrieve no eggs. So there could be a stopping point right there. People could get the eggs, but they don't fertilize, or they do fertilize, but they stop growing before they get to that blastocyst stage, or they get to that blastocyst stage and they're sent off for genetic testing, but none of the embryos have sort of the results that you're looking for. Or you get to that point, you have an embryo that looks sort of perfect for what you're looking for. It's transferred into the uterus and doesn't result in a pregnancy. So there's lots of different stopping points, and depending where you kind of put your starting point and your end point does in terms of what is success, that could vary. If somebody gets to the point where they have embryos that undergo genetic testing and that produces embryos that they're comfortable with transferring, then if the chromosome testing, the PGTA testing is also done, the chance of successful transfer is about 50 to 70%. But there are a lot of things that can happen along the way before you get to that point. So it's a little bit difficult to answer overall. And again,
Mhm.
because a lot of those factors are really personal, having a
Mhm.
consult with a fertility clinic, a reproductive endocrinologist as the doctor that would work there can often give people an idea of, for themselves, what's the chance of success? Are they going to expect to get a lot of eggs? Is the sperm quality going to be good from their partner? Is genetic testing going to be feasible for them based on, their family history, things like that? Those are all things that could happen as part of consultation before somebody actually starts taking medications. Not to say that it's always going to be a guarantee, even if you sort of get told that you've got a good chance of success. Um, but a lot of that can be done sort of by speaking
Mm.
with a doctor that specializes in infertility.
We had another question come in, and thanks for
Mhm.
answering that, Mira.
Yeah.
Here's the second question, and I think this is it, and then you can go on. Just to clarify, in order to do linkage analysis, you need to already know which of a person's parents is a carrier or affected with the condition, correct?
It's always helpful to know that, but it's not always needed. So, knowing which parent is a carrier or is affected, if there's nobody else in the family that's affected, like if you don't have an affected child, for example, is always going to be helpful. And in that example that I gave of the linkage analysis, I used parents
Mhm.
as what we call references. There are other people that can sometimes be used as references as well. So sometimes, like an affected brother or a child that's had genetic testing, for example. Um, there are also some PGT labs that can develop PGTM tests without involvement of family members using the embryos essentially as that second generation. Not every lab offers that. And in order for that to be available, it depends on your specific genetic variant. So,
Mm.
most genetic variants are amenable to that if you're working with a lab that's able to offer that. But there are some, like if it was a whole gene deletion, like the whole CHM gene is deleted, then that may exclude this no family member approach from being an option. So all of these cases are sort of evaluated on a case by case basis. Most of the genetic variants in CHM would probably be fine for to do without family members, but even in that situation, there are some challenges that can come up. Um, so the place to start is really, getting your own genetic testing done. And if you have family members that are open to having genetic testing, then having them
Mhm.
tested is always going to be helpful as well. But if if somebody's adopted or their parents are tested and nobody else has it, it doesn't mean that it's the end of the road. But there may be some other challenges that could come up in the process. Again, it doesn't mean that it can't be done. It just means that they'd want to sort of discuss their case specifically with their doctor, with the lab that's going to
Mhm.
develop the test for them.
Great. Thank you for answering that. That's all the questions we have so far.
All right. Great. So there we go. So, next, I'm going to briefly go over some of the other options that are available. So, one of these would be to pursue IVF. So, kind of similar to what we've discussed before, but instead of using your own eggs, to use donated eggs from someone who's not a CHM carrier, or to use embryos that were donated from, again, someone who's not a CHM carrier. Adoption is also an option that's available to any couple. And then in some cases, people have the option of medically indicated sex selection. So this could potentially be done in the context of IVF to select an embryo that is female, for example, to avoid the potential of having a child that's an affected male. Now, in some countries, including Canada and the UK, there are regulations on sex selection. Not to say that it can't ever be done, but it has to be done under certain circumstances. So, if this was something that you were considering, you'd need to speak with your local provider to see if that's an option for you. And then I've included here the reproductive options that are available for affected males. These options are a little bit more limited, and there's certainly overlap with what we've already discussed as available options for carriers. But briefly, affected men have the option, of course, to conceive naturally with or without genetic testing. If a man wanted to avoid passing on their CHM genetic variant, they could pursue the routes of sperm donation or donor sperm, donor embryos, or adoption, or possibly, again, that option of sex selection to avoid a female carrier embryo or pregnancy. And as I mentioned earlier, and I want to come back to this, there is no one right option for everybody. So if you're considering family planning options or you know someone who is, I encourage you to ask questions to me or to somebody else, to do some of your own research and to speak with a local genetic counselor who may be able to advise you on what the options are in your location. I do have some resources listed here for X-linked conditions. There's a great group called Remember the Girls for carriers. There's great support groups in there, and they've got tons of resources on their websites. I've linked here again to the FFB's genetic testing. The National Society of Genetic Counselors has a Find a Genetic Counselor tool on their website if you want to find somebody who's local to you. But if you can't find somebody who's local or that's proving really difficult, which unfortunately can sometimes be the case, there are several telehealth options where you can self-refer if you just want to talk to somebody about your specific situation and your options. Those are all available too. And then if you want to look into something like IVF coverage, um, one group, Resolve, does have resources state by state. And in Canada, the Government of Canada website covers a little bit about what kinds of provincial support there is for IVF and fertility treatments. So I can maybe put these in the chat or get them out to everyone in
I
another
think
way.
that would be super good. When we send the recording out, I'm sure Kathy, our executive director, or someone at the CRF will be able to connect this last slide and make sure we get that out to everyone.
Excellent.
Absolutely.
Yeah, and I've included my email there as well if people have questions. And then that's it for the slides. So happy to take more questions if folks have them.
We do. We have a couple more in the queue. And I think if I could say, I'm going to turn my camera back on here, just on the side here. This is a discussion that I think so many of the folks, the women and men, have at our conference. Just as a plug, our conference is going to be in June in Minneapolis. And so go to our website to definitely come to the conference and discuss these things. I don't want to say sensitive. It's a really good topic to discuss because many of us have had children, of course, with choroideremia and have choroideremia, so it's something worthy of discussion. Let me go to a couple questions. And you know what? Your presentation was really great. Thank you for doing it.
Thanks.
Here's the first question. My husband has CHM. His mother was a carrier. His two brothers and sisters do not have CHM. How can that be? Could they be carriers? Good question.
Great question. So maybe I can go back to one of my pictures here and share that again. And I think I may be able to use my mouse to
Sure.
point some things out. Can
Mm-hmm.
tell me if you can see my mouse. And I'm looking over here because it's on a different
Yep.
screen.
Sure.
All right. So this is kind of the scenario that's been described there. So there's a woman who's a CHM carrier, and she has one son, this individual's husband, who is affected, who has CHM. But for his mother, she has a normal copy as well. So for her other sons who are unaffected, who don't have CHM, they would have been expected to have inherited that normal copy of the CHM gene from their mother. So if they don't have CHM, if they don't have that diagnosis, then they almost certainly inherited that normal copy of the CHM gene and not the one with the mutation. they could certainly have genetic testing, depending how old they are, whether it's something that, they may have recognized or not. If they're adults, then probably would have been something that they would have been diagnosed with clinically, even without genetic testing, if they truly had it. For your husband's sister, it is possible that she's a carrier. In fact, it's a 50-50 chance whether she's a carrier or whether she's unaffected. So for her, considering carrier screening for choroideremia is certainly something that would be reasonable if she wants to know her status. Oh, I think you're muted.
Unmuted. Yep, absolutely. So I hope that helps answer the question. And if you have follow-up to that, go ahead, Elizabeth, and go ahead and ask your further follow-up question. Here's another question. Can you develop a PGTM genetic test ahead of time and wait a few years until you need it? Or
Mhm.
reuse the same test if you choose to have multiple children? Good
Mhm.
question.
Yeah. So it does vary a little bit lab to lab how that process works. So some labs, you develop the test up front and it can sit around for as long as you want it to sit around for. Now, theoretically, I should say, theoretically, it can sit around, but this is emerging technology and there's often changes to technology, and tests may get better over time, and the platform that a lab uses to do the testing can sometimes change. So, while theoretically a test may be available for many, many years, there's also a possibility that a lab may change its testing platform, and a test that was developed 1 year may not be available several years down the road. So, what I would probably recommend is developing a PGTM test or looking into that if that's something you're interested in, maybe 6 months to a year before you might be actually considering doing an IVF cycle. Um, you it doesn't mean you couldn't do it sooner than that, but things may change and you could find yourself in a situation where you paid a lot of money for something that you never got to use, which is not something that you want to be doing. But, if you were in a position where you had, for example, insurance coverage with one employer that you didn't anticipate being with, um, in a few years' time, that's something you could look into. But again, a lot of the costs and stuff will come when you do the IVF cycle. So it may still not necessarily be in your favor to, develop it several years in advance. If to answer the sort of the second part of the question, can it be used for, multiple children potentially? Um, yes, generally that's the case. But again, kind of depends. Like if you're doing multiple cycles within, a few years, then that test that was developed will probably still be available for you to use year over year. But if you're doing one cycle, 1 year and then 5 years later you're coming back again, you run the chance that it may not be available. Now, some people will have good responses to IVF and may end up with multiple embryos that have, unaffected, for example, results on the testing from a single IVF cycle. So one of the goals of the in vitro fertilization, that whole process of taking the medications, is to actually stimulate the ovaries to produce as many eggs as possible. So they really want to get a lot of embryos to make it worth your while to go through that. Now, again, people respond differently to medications. So not everybody is going to have a ton of embryos. And again, sometimes it does take multiple cycles, even just have one embryo that sort of fits the bill. But sometimes people will have one cycle that produces multiple embryos that fits everything that they're looking for. And those embryos can just stay on ice. If you transfer one and have a pregnancy, they can wait around until later for baby number two. Some people also choose to do multiple IVF cycles sort of right after the other or within a period of time and sort of bank embryos for the future. One thing that's not really a part of this conversation, but we do know that as women get older, that there's higher chances for chromosome conditions, which can cause embryos not to implant at all or to result in miscarriage. And so sometimes, depending on people's age, they may choose to do multiple cycles at a younger age to have more embryos that may, again, have better potential for pregnancies.
That was a question, Mira, is the age. I mean, is there a certain sweet spot and is there like an age in which you really should try to make these decisions?
There's not one sort of specific age. If you go online and you read, you may hear sort of after 35, people are considered advanced maternal age or geriatric pregnancies. Those terms float around, and people will usually cringe at them. And I understand, as somebody who's now in their mid 30s. Um, but but in terms of age, there's a few different things that plays into. It plays into genetically the chromosome, so not doesn't have anything to do with choroideremia, but there can be a higher chance for chromosome conditions. So this is like whole chromosomes that are missing or extra. And again, Down syndrome is an example of one of those where there's an extra number 21 chromosome, but most of the other chromosome conditions, like having a missing or extra number 1 chromosome, these are things that cause an embryo not to even continue to develop, or they could result in miscarriages. So if somebody's conceiving on their own, there can be higher chances for those kinds of pregnancy losses. There are also other complications in pregnancy that can increase with maternal age. I would say that a lot of those sort of significantly higher risks start to really ramp up in the later 30s, early 40s. So I don't think it's unreasonable to be sort of thinking about these things in your 20s or in your early 30s, but doesn't mean that if you're 40, it's too late to be thinking about all of these options. But unfortunately, we haven't figured out a way to turn time back on eggs and the aging of eggs. So age is still a factor that women especially have to consider.
Okay, we'll leave it there and not go on. Hey, here's another question we have. If the female is a carrier, can testing be done on her eggs before they're fertilized?
Unfortunately not.
Hmm.
So the eggs are basically a single cell. So in order to get the DNA out of them, that whole egg would have to be destroyed. So they can only be tested once they become an embryo and they've already divided so that they have a few cells
Hmm.
that they can spare for genetic testing.
Hmm. Here's another comment. Fantastic presentation. I have seen where there are a number of rare genetic diseases where there are recessive mutations, carriers by both parents. Are there any known cases of both parents carrying the CHM gene?
Um, I'm not aware of like a specific situation where that's the case, but it's certainly possible. It can happen, for an X-linked condition too. Um, I'd say it's probably very uncommon. The reason that with these autosomal recessive conditions, we can see more often two people being carriers is because typically the people that are carriers have zero symptoms. They never even know about it. And so the frequency of these genetic changes in the population can be a lot higher than for dominant conditions and X-linked conditions, for example. Historically, like if we go back, generations, it was maybe a disadvantage to be blind as an adult, and maybe people who had an X-linked condition that caused them to go blind didn't reproduce as much, so they didn't have as many children to pass on that genetic change. Whereas for a recessive condition, if somebody's a carrier and there's zero symptoms, zero health issues, they can proliferate in the population at much higher rates than, again, for
Mm.
dominant conditions or X-linked conditions. So while it certainly could happen that both a
Mhm.
man could be
Mhm.
affected with choroideremia and could have a partner who's a carrier, it's probably not something that happens a lot.
Here's another quick question. How likely is it that taking a sample of cells from the embryo damages the embryo?
Mhm. So the point at which the biopsy is taken using today's technology is when that embryo is pretty stable. And the risk to the embryo of taking that sample from that outer cell layer, the trophectoderm, is thought to be really low. Now, anytime an embryo goes through a freezing process and then theoretically being thawed later on, there are chances that embryos don't make it through that whole process. It's maybe on the order of about 5% of embryos don't make it through that. And taking the biopsy itself isn't something that causes, for example, a higher chance for a birth defect in an embryo. Oh, I don't know if my mic just disconnected.
No,
Um,
you're good.
okay. Um, Now, IVF in general is associated with a little bit of a higher chance for birth defects, like heart defects. That overall chance is still really small. In any pregnancy, we quote about maybe like a 2 to 5% chance for birth defects. And again, with
Is that
IVF, it's
higher than natural child rearing or,
the 2
or,
to
or natural
5% is
conception?
for, like, any pregnancy, natural
Okay.
conception, IVF, any pregnancy. With IVF, it's maybe just a little bit closer to the higher end of that range. So it's still overall, the chances are generally quite low, but it's a little bit
Hmm.
higher than in the general population with an IVF conception, but that's not thought to be specifically related to the embryo biopsy. So if an embryo was transferred sort of fresh without being frozen, without being biopsied versus an embryo that has a biopsy taken and is frozen, they're kind of on equal playing field.
Mira, are there any other considerations to, you did this is a great PowerPoint. Are there any other thoughts that you have or questions that we should be asking or you yourself thought of or any of your patients in regard to family planning that we're not asking? Um,
Mhm.
Anything else in
Yeah.
between the gaps?
I think these are really great questions. I think ultimately, when people are considering their own options, um, they have to think about what their own priorities are. And, again, if we're thinking like something like IVF and
Hmm.
PGTM, how that fits into, their goals financially as well, because it can be a pretty big, financial
Sure.
step and can't kind
Hmm.
of ignore that. Um, I think that, in the context of choroideremia, it's also really interesting, when we think about, how much money we as a community put into and want to continue to invest in curing choroideremia. And um, you know, when there's also options out there that people have to potentially, prevent it from, affecting the next generation in their family. And it'll be interesting to see, as these options become potentially more widely available, how that changed the landscape of the choroideremia community. Maybe there will be less people that have choroideremia, but maybe that doesn't really change a whole lot. Maybe there are still the same number of people, but you know, we also don't want to take away from the funding that goes into looking for treatments, looking for cures for people who are born with it, because there's always going to be people that have choroideremia who never knew about it, who don't have a family history or anything like that.
True.
So, there's
Hmm.
you know, big picture sort of ethical questions about all of this as well, which I think is really fascinating and not something that people have to necessarily be thinking about in their own, family planning considerations and journey. But I think it's for everybody that's here. I'm glad you're sort of educating yourselves on what those options are, because I
Hmm.
think that's the best thing that you can do for yourself. And then to be able to, consider what those options are and make an educated, informed decision.
Right. Hey, here we had another question come in.
Mm.
You mentioned testing for multiple things like Down syndrome and screening embryos. What is a typical testing panel?
Hmm. In testing embryos, it sounds like is the question.
I think so, yeah.
Yeah.
When screening embryos, what is a typical testing panel?
Hmm. So when testing embryos, there's kind of 2 to 3 kind of general types of tests that are available. There's the PGTM, which would be the testing for a single gene condition that is being inherited in the family. So that would be like what we're talking about for CHM. There's another kind of test that's called PGTSR, which is for known structural differences in the chromosomes, which isn't something that really applies here. And then there's this PGTA testing, which is testing that's available generally to anybody who's doing IVF in the US and Canada. And it is a non-specific kind of test. So it's not a test that looks for a list of things, but it screens across all 23 pairs of chromosomes for large differences in the volume of genetic material. So it's really looking to see, are there whole chromosomes that are missing or extra? Are there really large pieces of chromosomes that are missing or extra? And again, most of these are things that would affect the development of an embryo so early on that they fail to implant. They never result in a positive pregnancy test, or they miscarry early in the first trimester. There's really just a handful of whole chromosome differences that actually result in ongoing pregnancies and people can be born with. So Down syndrome is one of those where there's an extra number 21 chromosome. Trisomy 18 and 13 having an extra 18 chromosome or extra 13 chromosome. These are some others, or having differences in the number of actual X and Y chromosomes are some others. There are some other, what we consider sort of viable chromosome conditions that could potentially be detected in that kind of testing, where it's not a whole chromosome that's missing or extra, but a large piece of it. That it's almost infinite, the number of sort of possible variations that could be detected.
Mhm.
So it's not really a panel per se, it's more a broad test that's sort of picking up anything that's going to fit into that category. Anything that's big enough to be picked up in terms of a volume of genetic material difference would be detected on that testing.
Your parents would be very proud of you, Mira. You've done a great job tonight answering a lot of questions and studying. Somebody just said tonight, thank you so much. This was ever so helpful. You're welcome. Um, this is this is a hard topic to get your head around, and it's something that is near and dear to a lot of our hearts. Family planning is hard. It's important, but it's really great. Yeah. Oh, here comes some more comments, just again from a lot of the ladies that are younger women, perhaps, or maybe closer to our age. Thank you for this. It was so helpful. Thank you, says another person. Um, and again, we want to make sure, yes, please send those resources out. Thank you for the webinar and for your time, of course. We're grateful so much to you, Mira. And folks, if you like these type of webinars, this is something that the CRF really is valuing, and we want to make sure that we give you every kind of information and support and encouragement as we continue. So if you would ever like to give a donation to the CRF, you can do this. You can go to the curechm.org and make a donation. Um, but thank you. Thanks for your time. It's getting kind of late here on the East Coast time. It's 9:30. You know what? We have something else. Can I ask you another question as they're coming in here? Just the last one.
Yeah.
Or yes, as Kathy mentioned, of course, to the CRFC in Canada. That's also really important. Yeah, make sure we say that. This is near and dear to a lot of our hearts, and this is what's coming in. We have another family, a couple that just said, thank you so much for this. It was extremely informative and very helpful as my husband and I are family planning as I am a carrier. Absolutely. Here's another comment. I am currently going through the PGD process after a lot of consideration, and I feel very validated by your talks. Cool, thank you. Good. Excellent.
I'm so glad that it was valuable, and I'm right there with everybody, so I
Mhm.
can totally relate. And again, I'm super glad that this was helpful, and yeah, hopefully we can get those resources out as well. And if there are other questions, people can let me know.
I think that's what makes it even more special is when we have somebody who kind of has a heart investment, such as yourself. You understand, and we appreciate that even more. So thank you.
My
So to
pleasure.
everyone else, it's snow has stopped, and we just wish everyone a wonderful evening. Thank you for joining us, and Mira, thank you. Hopefully, your folks are enjoying. Your dad did come in. He was in the chat group, so they'll enjoy their time away. Thank you, everyone. Have a great evening, and we'll see you soon. Bye.